Welcome back to the Deep Dive. Our mission today, it's laser focused. We are giving you that structured shortcut you need to really master essential gastrointestinal system assessment. This is specifically for that high-stakes world of med-surg nursing. We're going straight from, basic anatomy right through to critical diagnostic management.
And yet, before we jump into all the layers and labs, let's just frame this. Think about the lenses you need to use for every single GI patient. These are the three big interconnected priority concepts: nutrition, elimination, and pain. Everything you see, every cue you pick up, it's going to relate back to one, two, or maybe all three of these.
That really is the so what, isn't it? Okay, so let's unpack the structure behind all that.
Okay.
The architecture of the GI tract itself. It's this, 25-foot-long canal, but clinically what matters most, the wall layers. You've got the inner mucosas, sure, but the layer that really drives things provides the push. That's the muscularis. It's smooth muscle, circular and longitudinal, absolutely essential for motility.
Motility is definitely key. But don't forget the other four core functions: secretion, digestion, absorption, and of course, elimination. And digestion, just to be clear, is that whole process of breaking down complex food into simpler forms, into that liquid mix we call chyme. This takes, a really coordinated effort from our accessory organs.
Right, the chemical breakdown crew, and some of these are fascinating. The stomach, okay, it secretes hydrochloric acid, vital for breakdown. But the thing that surprises a lot of people, it also makes intrinsic factor. And if you lack that intrinsic factor, boom, you cannot absorb vitamin B12. That leads straight to pernicious anemia. It's such a tiny factor, but wow, huge consequences.
It really is. And the pancreas, sometimes it gets overlooked, but it provides the real heavy hitters: amylase for carbs and lipase for fats. You see fat in the stool, steatorrhea. Your first thought should be, maybe a lipase problem.
And then there's the absolute powerhouse, the liver. Over 400 functions. I mean, it's incredible. Storage, protection, metabolism. I'm always struck by the protection part. It's got these specialized cells, cup for cells, kind of like the GI system's bouncers, right? They engulf bacteria, detoxify stuff like alcohol, drugs.
Exactly. And that protection, that detoxification function, it is absolutely vital for patient safety, especially as we get older, because, decreased liver function is pretty common in adults over, say, 65. Their ability to process medication slows way down, and this dramatically increases their risk for drug toxicity. Standard doses can just build up much faster.
That risk calculation is so important, which takes us right into recognizing cues when we're taking the patient history. You just mentioned age for drug metabolism. Age is also a huge risk factor for specific diseases. Older adults, higher risk for stomach cancer.
Yeah.
But we're also seeing rising rates of colon cancer in younger adults, often linked with obesity.
And physiologically, aging hits those core concepts hard. Nutrition and elimination especially. Structurally, the gastric mucosa can atrophy. That means less hydrochloric acid, which we call hypochlorhydria. And remember, less acid means impaired absorption of B12 and iron, so it's like a double whammy,
Yeah.
Lack of intrinsic factor or lack of acid can jeopardize B12 absorption.
Okay, and on the elimination front, what specific physical changes cause that chronic constipation we often see in older patients?
It's usually a combination. You get decreased peristalsis, that muscle push just isn't as strong, and also dulled nerve impulses. So the actual sensation, the urge to defecate, is reduced. This leads directly to constipation, sometimes even impaction. Plus, remember that lack of pancreatic lipase we talked about? If fat isn't digested properly, it shows up as steatorrhea, those fatty, kind of foul-smelling stools. That's a really key elimination cue you can see.
Steatorrhea is definitely a clear sign. But if the main cue is pain, nurses really need a system. And this is where the PQRST mnemonic is just indispensable. P, precipitating or palliative factors. Q, quality or quantity. R, region or radiation. S, severity scale. T, timing. It forces you to get the whole picture of their discomfort.
And you absolutely need to ask specifically about certain GI symptoms patients might downplay. Things like dysphagia, difficulty swallowing, or anorexia, which is loss of appetite, not the eating disorder here. Also dyspepsia, that's your heartburn, that chronic burning feeling in the epigastric area. And crucially, ask about any changes in bowel habits. Color, consistency. Especially ask about frank blood, bright red, or those black tarry stools that suggest GI bleeding. And we always have to consider culture and genetics too. Like lactose intolerance, it's not just a minor issue for many. It's a genetic reality for a huge portion of the world, particularly people with non-white heritage, Asian, South American, due to not having enough lactase enzyme. And clinically, genetic things like FAP, familial adenomatous polyposis, mean much more aggressive colon cancer screening is needed because the risk is just so much higher.
Okay, let's shift gears from history to the hands-on physical assessment. Because the sequence here is non-negotiable for generalist nurses. You need the patient comfortable, relaxed, empty bladder, lying supine, knees bent a bit.
Right. And the specific order, the required order is inspection, auscultation, and only then light palpation. Percussion and deep palpation are typically done by providers, and there's a very clear reason for this order. If you start poking around, palpating, or percussing before you listen, you can stir up the bowel. That can artificially increase intestinal activity and make you think you're hearing hyperactive sounds when it's really just from the palpation itself.
Makes sense. So starting with inspection, you're looking for obvious things, asymmetry, distension, maybe bulging flanks. But here's something really critical to watch for. Visible peristaltic waves moving across the abdomen. It's rare to see them. But if you do see those waves, that is a critical, urgent finding. It could indicate a complete intestinal obstruction.
And that brings us right to the first major, potentially life-threatening safety alert you need to know.
Nursing safety priority. Action alert. Okay, listen up. During inspection, if you see a bulging, pulsating mass anywhere on the abdomen, anywhere you stop, you absolutely do not touch it. Do not palpate it. This strongly suggests an abdominal aortic aneurysm. Stop the assessment immediately. Notify the provider. Pressure could cause a rupture. It's that serious.
That is a critical stop sign, absolutely. So, assuming inspection is clear, no pulsating mass, we move to auscultation. You're listening for those normal bowel sounds, the high-pitched gurgles. Usually 5 to 30 per minute is the standard range. We know hypoactive sounds, quieter or fewer sounds, often happen after surgery or maybe with peritonitis, but really high-pitched, loud, rushing sounds, that's called borborygmus. It often signals really fast motility, like with gastroenteritis. Or, more worryingly, it can mean hyperactivity above an obstruction, where the bowel is trying hard to push past a blockage.
There's actually a second safety check during auscultation related to vascular sounds. You need to specifically listen for a brute. That's swooshing sound over the aorta, the renal arteries, and the iliac arteries.
Exactly, and that's our second really crucial safety alert. If you hear a brute, especially over the aorta, it's another potential sign of an aneurysm. The rule is identical to seeing the pulsating mass. Do not proceed with palpation or percussion. Stop. Notify the provider immediately. Patient safety first. Avoid putting any pressure on what could be a compromised vessel.
Okay, so physical assessment cues gathered, safety checks done. Now we move into diagnostics. Lab tests help confirm what we suspect. For instance, labs help diagnose anemia, which might point to GI bleeding, right? Or they show how specific organs are functioning.
Yeah, for liver damage, we're looking for elevated AST and ALT enzymes. Those are key markers. We also look at clotting time, the PT, prothrombin time, because if the liver isn't working well, it can't make clotting factors properly, so the PT gets longer, it takes longer to clot. For the pancreas, acute pancreatitis usually shows up with elevated serum amylase and lipase. What's interesting here, though, is that urine amylase often stays elevated longer, maybe 5 to 7 days, even after the serum levels start coming down. So it gives you a bit of a wider diagnostic window.
We also look at bilirubin for jaundice, obviously, and ammonia levels, too. Ammonia builds up if the liver can't convert it to urea.
Right. Now, moving on to screening, particularly for colorectal cancer. Early detection is so important. The American Cancer Society now recommends starting screening at age 45 for average-risk adults. And we have, well, sometimes it feels like an alphabet soup of screening tests available now, especially the take-home ones.
Let's quickly break down the three main at-home options. There's the older one, the GFODT, the guaiac test. That's the one that requires you to tell patients to avoid certain things, red meat, NSAIDs, vitamin C for several days beforehand because they can cause false positives.
Then there's the FIT, the fecal immunochemical test. This one's generally preferred now because it's not affected by food or drugs. That makes it much easier for patients to do correctly, and the results tend to be more reliable.
And the third one is the sDNA test, like Cologuard. It's convenient. You do it at home, usually every 3 years. Medicare covers it. And this is really important clinical judgment for patients who are genuinely high risk, meaning strong family history, maybe they have inflammatory bowel disease, or they've had polyps or positive screens before. These home tests are not enough.
Absolutely right. Those high-risk individuals still require a traditional colonoscopy. You need that direct visualization and the ability to biopsy right then and there.
Which brings us neatly to invasive diagnostics. These always require signed informed consent and often moderate sedation. Let's start up top with the EGD esophagogastroduodenoscopy. This lets us see the esophagus, stomach, duodenum. Prep is pretty straightforward. NPO for 6 to 8 hours before. Avoid anticoagulants, NSAIDs usually.
Okay, post-procedure nursing for an EGD. There is one single overriding critical safety priority. You absolutely must maintain NPO status until that patient's gag reflex is fully returned. They spray the back of the throat with a local anesthetic, which knocks out the gag reflex. If the patient tries to drink before it's back, the risk of aspiration is incredibly high. This usually takes about 30 to 60 minutes, maybe a bit longer. You have to check it carefully before giving anything by mouth. Vital signs monitoring is also key, every 15-30 minutes initially.
Got it. Gag reflex first. Okay, then there's the colonoscopy, looking at the entire large bowel. Recommended every 10 years for average risk adults starting at 45. And for this one, the prep is everything. It's usually a clear liquid diet the day before, no red, orange, or purple liquids or gelatin, because those can look like blood. Followed by whatever bowel cleansing solution the provider ordered could be Golightly, Suprep, sometimes laxatives or enemas too. But the bottom line is, if the prep isn't adequate, the doctor can't see properly, and the whole procedure might have to be repeated.
Exactly. And during recovery, the nursing focus shifts significantly, especially concerning elimination.
Right. Post-colonoscopy, you're watching vital signs very closely, again checking every 15 minutes initially, looking for signs of perforation like sudden severe pain, fever, bleeding. But a key nursing intervention is positioning. Keep them NPO until they're fully alert, definitely, and encourage them to lie on their left side. Why? This position helps promote passing flatus gas. Passing gas is actually a really good sign. It means peristalsis is returning, the bowel is starting to move again, and it helps relieve the distension from the air they insufflate during the procedure.
And just briefly, a couple of others to mention. There's ERCP, which looks at bile ducts in the pancreas. It's often therapeutic, maybe removing stones or placing stents, but it carries a higher risk of complications afterward, like pancreatitis or even sepsis, so monitoring needs to be really vigilant. And then VCE, video capsule endoscopy. The patient swallows a tiny camera. It's great for seeing the small intestine, which is hard to reach otherwise. The nursing part there is mainly teaching and then confirming the capsule has actually passed. If it hasn't passed within, say, 2 weeks, that could indicate an obstruction, which is a concern.
Wow, okay, that was a complete circuit of the GI system, wasn't it? We started with the basic architecture, understanding things like intrinsic factor, the liver's detox role. Then we walked through those absolutely essential physical assessment safety checks, never touching a pulsating mass, never ignoring a brute, life-saving stuff. And we wrapped up with the really precise nursing strategies for diagnostics, like the critical priority of checking that gag reflex post-EGD and making sure that colonoscopy prep is done right.
Yeah, the big clinical takeaway here is that really mastering these steps, understanding the why behind them, it's fundamental. It's about being able to interpret all the cues, whether it's from the history, like a patient describing dyspepsia, or a physical finding like steatorrhea, or a lab result showing high lipase. That's how you provide solid, evidence-based care that's squarely focused on managing nutrition, elimination, and pain.
So here's something for you, our listener, to think about. We mentioned that the GI microbiome can get disrupted with aging. Considering that, what proactive, non-drug interventions could you maybe implement in your own life, starting now, to support your long-term GI immunity and maybe even improve your elimination health down the road? Definitely time to apply this knowledge. Thanks so much for tuning in to this deep dive.